history of slightly low T and a vitamin D deficiency that decided to start working out a little bit more. He started walking on a treadmill, felt some hip pain, and a couple days later he felt extreme pain and couldn't bear weight, presented with these x-rays. So I guess the discussion is treatment. Dr. Lorei.
He's 45 years old. What other comorbidities you said?
He's overweight. He has a history of low T, and he has a vitamin D deficiency.
So, I would say you have to have a discussion with the patient. I believe it's a reasonable thing to replace this patient. Total hip arthroplasty would be preferable to hemiarthroplasty. But I think if he is of the mindset that he wants to save his bone, then I think it's a very reasonable thing to reduce this and fix it as long as he understands that there's an increased hazard risk.
Dr. Brady, implant choice? Or do you agree with the assessment? Would you go ORIF versus total hip? Or?
So I'd say based on what we just learned that I'm really thinking in my mind that a total hip may be the best option for this patient given that he's got some comorbidities. I think still given that, at this particular moment in time, I would err on the side of ORIF with an anatomic reduction. I'd probably talk to this particular patient about we're going to go to the operating room and you're going to come out either with it fixed or with it replaced depending on what I find in there, and I'd approach it anteriorly both ways so I could look at it and see. But I would try my best to fix him and then say, if we fix you, you may need a revision sooner rather than later, but just his age really makes me think I don't want to go right to the arthroplasty, and then afterwards he's going to have a discussion with the endocrinologist.
Okay, Dr. Graf?
Yeah, I would fix him. Like the comorbidities were low T, right? Which is I give him a pill for that, and the other one was he's fat, right? But he's just started working out.
Vitamin D deficiency.
Oh, okay, well I'll give him a pill for that too.
Yeah.
And I would fix him.
Okay.
Yeah. The only thing is, next to me is our cancer doctor, so he's going to get nervous.
Yeah, he just has a vitamin D deficiency at the time of presentation. All right. Well, we went through that. This is what we did. Actually performed a close reduction on this patient. Any criticism or critiques? The view on the right is a lateral x-ray. I just couldn't get the whole thing in one shot.
I would say your reduction looks really good, especially for a close reduction looks excellent. I don't think you could do better than that open. And it looks like your hardware position is good. I'm not a trauma guy, but I would bet you probably want that DHS screw in a little deeper, lesser apex distance, or is that?
Hey, tip
No,
apex looks
good.
fine.
Okay, fine.
The mediocalcar looks a little bit off, but I need my glasses. Is it okay?
It's awful. I mean, you can see a little where the fracture is, but I mean,
But that's where the
I'm not
money
going to
is.
quibble with that because I'd take that reduction if I saw it.
Right.
Okay. Oh, this is his PACU film. And then 2 weeks later, he comes back like this. And he's been compliant. I made him toe touch weight bearing on crutches. He hasn't been doing anything crazy. He's a really compliant person. So what do we think?
No, I think you're going to expect some shortening in this. It's only 2 weeks. I wouldn't call it a failure yet. I wouldn't go rush to do anything yet, but he's definitely shortening. I'd give him some more time, keep him toe touch probably for another 6 weeks or so and just keep following it and looking at the head, making sure he doesn't get AVN, and hopefully that neck will heal. He's going to be short though.
Any other opinions? And we did refer him to an endocrinologist while he was in-house and put him on vitamin D and all that stuff. All right, so I believe we kept him non-weight bearing for about 6 weeks and then toe touch, and then made him partial for a little bit and advanced his weight bearing. But unfortunately, this occurred at 5 months. So there was another discussion. Dr. Lorei, what do you think?
So he's got a non-union now, and he's got broken hardware. So your choices at this point would be removing the hardware, performing osteotomy to try to get him to heal, or replace him. And I would vote to remove the hardware and replace him.
Dr. Brady and Dr. Graf?
Yeah, 5 months out, and he's 45, right?
And at this point, we've corrected all of
He's
his
optimized,
endocrine
yeah.
problems. Like he's
I
perfect.
think you could get him healed, but he's going to have a pretty bad gait pattern with a valgus osteotomy with that deformity, I would think. I would err on the side of total hip here, because coming back after an osteotomy, if you have to, is a nightmare. And this is pretty pristine. This hip's pretty pristine. It'd be an easy total hip.
I'd agree with that 100%. I mean, the trauma surgeon in me wants to do a valgus intratroch osteotomy because you think that's what you're supposed to do, but I mean, hip replacements are great these days. I'd give him a hip replacement and keep going.
All right. I did have a discussion with him about both treatment options, and he actually wanted me to preserve his hip. So went ahead and templated him. They've discontinued the double-angled osteotomy blade plates. So sometimes they're hard to get. So I templated him with a DHS. And this is what we ended up with. I included that lateral x-ray on the right because they got the hemovac perfectly placed over the x-ray of the PACU. And we used that troch plate because some of the criticisms of this technique article were that you were creating a potential reversal obliquity fracture with a DHS, so I put that in as a safety precaution. So any critiques about?
Chris, I'm not sure what that lateral plate does. You have to explain that to me. I don't know.
The troch extension plate is basically something that would reconstitute a lateral wall. Say you have a lateral wall fracture in an intertroch, intertrochanteric femur fracture with a lateral wall breach, and you put a DHS in that, it will have uncontrolled collapse and it'll fail.
So the lateral side will.
So it'll
It's a
reconstitute.
buttress to push it back.
Exactly. I
Okay.
think Dr. Graf showed a case where there was a lot of greater trochanteric comminution, and that trochanteric plate will reconstitute the lateral wall to prevent failure.
And where does that sit laterally? Is that incorporated into the barrel, into the side plate of the DHS?
Yeah, it sits on top of it
Gotcha.
flushly,
Okay, fine.
and two of the screws in the shaft of the plate will push it down.
Yeah, you're right. It's hard to find a blade plate anymore.
Yeah.
This is a good construct. But what size is that? Is that like a large frag extension or something, like 4 or 5 locking or something? Or?
This is I'm just going to mention this, but it's a Synthes, it's the trochanteric stabilization plate, but I think all companies have something like this now, but.
It's
Yeah.
the key to your construct there, really.
Yeah.
Yeah.
All right, and then we moved forward, and 6 months out, we actually started, I think the osteotomy site is fully healed, and the femoral neck looks like it is starting to heal. He has no pain. He's walking without a limp. He's doing pretty well now. I'll see him back around a year and see how he's doing.
Looks great. Yeah, looks great. How's his gait? Gait's fine?
It's pretty good. Yeah, he doesn't have a limb length equality. He's not complaining of any like lateral pain or anything like that. He's doing pretty well. And I know they don't always, I did another one of these and the person's miserable, so I think it depends on
I think it's good you
mindset.
talk to him and let him decide, that they
Yeah.
can go down swinging.
All right, that's all I got.
Good case.